It is 12:33, so I am going to go ahead and get us started. My name is Elizabeth Richardson. I am the CEO of Altum Healthcare Solutions. This is our deep dive series where we take a deep dive into topics affecting hospital revenue cycle. This was a kind of pop-up deep dive. We were taking the summer off. A lot of you were on our first pop-up deep dive when the Senate passed the first version of the big beautiful bill. And now that we have the finalized version passed and signed into law, we had a lot of people requesting that we get back on here. So I'm joined today by Donny Zamora, who is, in addition to being the former CEO of Invicta, is a good friend and mentor of mine. We worked together in the Medicaid eligibility space at Boulder Healthcare Solutions. He taught me everything that I know. So really excited to have this conversation today with you, Donny. So thanks for joining us. When we talked about this a few months ago, we were looking at approximately $800 billion of Medicaid cuts, and in this finalized version, we are now looking at close to $940 billion of Medicaid cuts. So it has gotten worse instead of better since the last time we talked. Larger implications on eligibility for Medicaid, stronger work requirements. They are going to lower the provider tax from 6% to 3.5% over time, whereas the Senate was originally going to hold that in place. So we've lost even more money since the last time that we talked. We've lost even more eligibility since the last time we talked. The thing that we have gained is the $50 billion for rural health, which I know that you're going to hit on. But just for everybody on the phone, the big beautiful bill, we're looking at a $1.2 trillion with a T dollars cut in Medicaid funding through 2034. So this is a really, really big deal. They're expected to lose 11.8 million people to become uninsured and 16.9 million to become insured over the next decade uninsured. So it's just a really, really big deal. Donny and I were talking before this. It's like there's so much information that you almost, don't know where to start talking about the implications of this. And that not just are you looking at a situation where a lot of people are going to be ineligible for Medicaid, either because of the changes in requirements or because they can't keep up with the changes in requirements, but you're also looking at a situation where the people that are enrolled in Medicaid are probably going to be enrolled in a much lesser version than the Medicaid that they're enrolled in today. So it really is going to affect all Medicaid recipients, not just the ones that are knocked off the roll, which is something that's not getting a lot of attention right now. So, Donny, where do you want to start?
Let's start with let's handle the people side of it. Let's start on the potential link to the social determinants of health and food scarcity.
I love that. Yeah, so one of the things I've been reading a lot about is the food insecurity problem that they're expecting to come out of this. I think I saw an estimate this morning that just falling off of the SNAP benefits from the people falling off the Medicaid rolls, there's going to be 3 million people. And there already is food insecurity in 38% of Medicaid households. So that's a really big deal that, of course, leads to a lot of community impact, a lot of health impacts. There's been a lot of conversations about we're going to be in a situation where people are going to be showing up at hospitals because they're hungry. Can you talk more, Donny, about what you've seen in the Medicaid population and what the addition of the SNAP benefits means to just their overall health?
Well, I mean, it is their livelihood in essence, it's their way in which they provide food to their families. So, there's 71 people are enrolled in Medicaid. 42 million of those people also receive food stamps. And to be able to take away that benefit is just going to be crippling to a lot of communities. And, from a social determinants of health standpoint, the 20% of health outcomes are determined by the clinical care they receive, and the 80% of outcomes are directly tied to their physical environment, food, and the behavioral factors. But patients facing food insecurities, they cost 2 times the amount of patients that are properly fed. So the food insecurities are going to lead to longer hospitalizations and just higher readmission rates because their bodies aren't going to get enough to function. So it's a growing concern with regard to whereas there was so much there were so many benefits that were added during the CARES Act during COVID that offered school and lunch paid for in some of these lower socioeconomic areas. So I'm trying to find out if is that going to be impacted as well, because there are so many, let's face it, there are so many kids that get 2 of their 3 meals from the school district, because there's many households that unfortunately are able only to support 1 meal a day.
Yeah, it's really scary, and I think as of right now, 1 in 5 Americans are on Medicaid. So this is a huge population, 77 million people. So we're talking about a massive impact across the board. What other social determinants of health are we looking at? Because I think also one of the big things is the access to the rural health and what that is going to do to these populations in the rural healthcare space, where almost all of their reimbursement comes from Medicaid.
I'm sorry, say that one more time, Elizabeth. What was your question?
Yeah, so I was thinking about the other social determinants of health, and one of them is access to care. And so in the rural markets where Medicaid is basically supporting, almost 100% or 98% of the hospitals or the critical access hospitals budget, what is going to happen to these populations when they, no longer can access care, or they're hours away from accessing care? And the impact of that. Also, the rural population already is considered much more unhealthy than the city population, and you have a lot of people in those populations. That's where you have your farmers and things like that. That we have so many questions about how are they going to meet these work requirements.
Yeah, that's a great point. And with regard to what's going to happen in rural America, I mean, it's my belief that we're going to create healthcare deserts where people are going to have to go travel a long ways in order to find healthcare. And so you talk about access to healthcare, then you also have to talk about education as one of the other social determinants of health. So, that's a perfect segue into like the rural health. They're appropriating $10 billion per year from 2026 to 2030, a total of $50 billion to support rural healthcare, and it's $10 billion a year. I mean, $10 billion a year. So, in that, the states and not the respective hospitals have to apply for this type of assistance. So the hospitals have to make sure that they are linked in with the state using lobbyists or whoever blowing up their phones to make sure that there was someone at the state that was applying for all of these funds and making sure that they meet the application requirements. And then like from a state level flexibility standpoint, there are so many of the states, and especially in some of these rural areas, they're going to have to reallocate the funds in order to to meet the need. Because you said like, how are they going to track someone's work credits? And you bring up a farmer. A farmer doesn't check into anyone. He doesn't get a pay stub. It's like, how is a farmer going to prove that they work? What, you going to get a note from the neighbor? No, that's not going to work. So there's just a lot of nuances as it pertains for those, not only in rural areas, but others. So I think in some of those rural areas, I think those are going to be the most hard pressed, because they're going to be faced with doing things that they've never, ever had to do before. Not to say that they've never had an uninsured population, but just imagine the stress of the strain that this is going to put on a local office that maybe is a 2 to 3 person shop, who now has to, they have to re-verify eligibility benefits every 6 months instead of every year. So it's gonna become a burden, and it's gonna be it's going to be very difficult. And I believe it's going to be crippling for both not only the state agencies, but for the population that live in and around rural America.
Yeah, and I think you mentioned the Rural Health Transformation Program. That is something that was created in this finalized version. That's where the $50 billion comes in. But I don't think a lot of people realize, to your point, not only can the hospitals not apply directly, that the states have to apply, but that application has to be in by December. So we're less than 6 months from having to have a plan, statistics, and it's not just a, hey, you say I'm rural and I want money. These are some of the things that CMS is going to judge applications by, which is just interesting in itself. Like, how do you judge which rural health providers need more help than others? But they are going to look at patient outcomes is actually one of the judging things for getting the funding. Well, as we just talked about, patient outcomes are going to be affected by the inability to access food and the inability to access care because they come off the roll and they don't have Medicaid. But then we're also going to use those patient outcomes to judge the rural health providers, necessity of receiving these funds. They have to boost clinician recruitment and training programs. That has already been happening in the rural health space. That's also being significantly impacted by the government's attempt to do away with the loan forgiveness program for federal employees. There's been a lot of conversation about, doctors, that there's already a shortage of doctors. We need doctors to come into these rural communities. But now, we're asking them to come into a rural community on a very limited budget with $1 million of medical debt. And that's not sustainable. They want them to create data-driven strategies to provide care close to the patient's home. And then develop long-term financial solvency models, which it's like, how are we supposed to develop a long-term financial solvency model when you're taking away all of the money? So I think just the things that they're looking for in the actual application to get the funding are all being affected by other parts of this bill. And again, you have 6 months to do this. And, they're asking for you not just to recruit clinicians, but to have 5-year employment contracts. So in the next 6 months, where are rural hospitals supposed to find all these physicians and get them on 5-year employment contracts? And then it's, asking them to, invest in technology. Well, most rural hospitals are running on a 3% margin at best. So they don't have money to go invest in technology in order to be eligible for this additional benefit. So it's going to be really interesting to see how this comes about, how any rural hospitals can even, qualify for this assistance under these guidelines. And, to your point, Donnie, like, the states need to get moving now to figure out what they're going to include in their applications.
Yeah, and I think from a technology standpoint, I think the rural USA and the state agencies, I think that's where they need to start with regard to operationalizing how this is going to work, especially with regard to work credits, because let's face it, the county offices don't have the technology that we have out in the RCM vendor space. They don't have the ability to accept a snapshot of somebody's wage verification and get that ingested into our system and then send it back into their system, or any system, any Medicaid enrollment company out there. They have a way in which to obtain the wage verifications, the domicile information, proof of residency, things like that. So how is, not in rural America, is like, not everybody has Wi-Fi. Not everybody has broadband. How are they going to download the forms? And then better yet, are the states going to be able to accept the picture from somebody's phone? Because in many cases, that's the only machine that they have. They don't have laptops, and then you throw in the challenge of literacy, both in reading and technology. So the mean Medicaid enrollee was found to have to read a 6th grade education. It was actually 5.6, but I'm rounding up to sixth grade education. So the impact of low literacy among Medicaid members, it contributes to the worsened health outcomes, their higher costs, and many exacerbate their health and their health care disparities. So it's a pretty high fence for both the county agencies and the rural facilities.
Well, and you're looking at a situation where, I mean, I have a law degree and I can't answer questions trying to read through this and understand what's required. So to your point, there's no chance for an average Medicaid recipient. There's no chance for the average person that, has dedicated their life to social work that's working at the Medicaid office to be able to figure this out. If you and I, having spent our whole careers doing this and being highly educated, can't figure it out. I mean, that's just it's just bizarre to even believe that they would, be able to do that. I think that that is the big concern, is that people that should be eligible for Medicaid, obviously some of what was pushing this initiative was the Medicaid fraud and the assumption that, there are people that are using the Medicaid system. But I think the bigger concern is the people that are going to get kicked off the rolls that actually should qualify. But to your point, they can't get the information that they need, or they don't know they're supposed to get the information. And I'm also pretty sure that in most, or not most states, but in a lot of states, the access to the free cell phone is also attached to SNAP and Medicaid. So some of these people only have a cell phone because they have access to these benefits. So, that's going to make it even worse if you take the cell phones away and they don't have Wi-Fi and they live in the middle of nowhere. Let's go back and just talk about this community engagement requirement for a minute. It's been called the work requirement, but the actual official name for it is the community engagement benefit. So it basically says that a enrolled Medicaid beneficiary has to have 80 hours a month of community engagement, which they define as working community service, participation in a work program, enrolled in an education program at least part-time, or a combination of the above. So, and non-compliance results in immediate disenrollment and prevents you from being able to get a premium tax credit on the exchange. There's been a lot of conversation, about this. We've already hit on some things like farmers, self-employed people. Like, how do you track this? How do you track it if somebody, how many hours of school versus how many hours of work? Does it have to be an actual attendance in school? Does it just be enrolled in school? Like, there's so many questions. And one of the things that I've been reading about, even in particular, is childcare expense. The average childcare expense in this country is $25 an hour. And so you're telling this population that's already below the federal poverty line that they need to, go out and work 80 hours a week. But we now also have, $25 an hour childcare that they're having to pay, which is putting them in an even worse financial position to make them work. There's also a lot of conversation about the over 50 population. Usually over 50, they've had some chronic health conditions arise. Also, a lot of the over 50 population is facing age discrimination. If they do try to go out and get a job, they're no longer eligible for a lot of the labor type manual jobs. And then particularly for the females in that population, a lot of them are caregivers. They're caregivers to their elderly parents, they're caregivers to their neighbors, they're caregivers to disabled adults, which is not an exclusion. A disabled child does give you an exemption to the work requirement, but not a disabled adult. Georgia, in my home state, is one of the only states that currently already has a work requirement in place, and the state has spent close to $100 million just on the administration of trying to set up the program. So that's the other thing is, who is going to cover the cost of these states setting up these programs and these offices that are already overburdened, having to get up and running on how to even verify all this stuff.
Yeah, there is a lot to be done for sure. And but you're a lawyer?
Yeah. Stayed at a Holiday Inn Express last night.
We'll leave the lid up for you. But no, with regard to, it is just such there's so much to do. And I hope that from both the state from a state facility standpoint and from in the rural America and also like Hospital USA that we all, work in and we vacillate through all of that. We work with all of these populations. It's just, there has to be a master architect behind it to make sure that there is not any administrative loopholes that are missed, to make sure that each and every state and county get the monies that they're that they're entitled to, because so much of reading all of this BBB is like reading a contract that has a bunch of clawbacks, right? Everybody out there, understands what an SLA is. There's clawbacks, there's performance guarantees. It's almost like they're putting so many kind of like performance things that people have to meet in order for them to retain benefits that they used to get for free. And of course, I understand the need for greater accountability. I'm just trying to, in my little head, I'm trying to figure out why such aggressive stances, because when you think about Medicaid fraud, you hear Medicaid fraud, and I think the people that are on Medicaid that shouldn't be, I don't think that is a huge number in the grand scheme of things. I think the majority of healthcare fraud comes from the machine of healthcare. People that start, ghost billing agencies, or they start billing ghost Medicare patients, or they just bill for one procedures. Like, you hear it all the time. I mean, Google Medicaid fraud this morning, and you'll probably bring up 3 or 4 cases that just happened last week that total $300-400 million of abuse. So, it's one of those things to where it's like, I think those that are in most need and those who work with those in most need, they're getting a lot of the services taken away from them. So we as a universe have to like make sure that we give everybody the data that they need in order for them to navigate through this new reality of Medicaid.
Well, because at the end of the day, like everything, it's going to fall on the hospitals to assist these patients, to help them figure it out, to try to help them get coverage. Because they're not going to know that they don't have Medicaid until they show up at the hospital door in some cases. Because what Donnie was referring to is, some additional things have been added or included in the bill. One is a 6-month redetermination for the expansion populations. Currently, Medicaid redetermination happens annually. That's being moved back to 6 months for the expansion populations, and so that's a big deal too. You're looking at doing twice as much work every year to get patients enrolled. The retro period from Medicaid is is currently 6 months, and it's rolling back to 2 months or 1 month in expansion states, which is a big deal again for hospital providers when you have chronically ill patients. One thing we haven't touched on is the new kind of cost share with a Medicaid patient having to pay $35 to receive, I think, emergency services and inpatient and some other things are excluded from that list. But basically, to go on an outpatient for an outpatient procedure or go to a doctor's appointment, they're now making the cost share for a Medicaid patient $35. Right now it's $3. And anybody who's done this for long enough knows that we hardly ever get the $3, hardly ever. And now we're asking for $35, and you go into things that I just, said, childcare is $25 an hour. So if you got to somebody's got to watch your kid to go to the doctor. So you paid $25, $20 for childcare. You paid $35 for your Medicaid copay. It's just not sustainable. These people don't have this money. Minimum wage is $7 something an hour. And it just, I can't fathom how we're going to ask somebody to pay $35 that we know is on this program because they don't have any money. And then what's really different about it is that it now specifically states that providers can reject Medicaid patients. So in the past, providers would not reject Medicaid patients for the inability to pay that $3. Now it specifically says in the law that if they can't pay the $35, you don't have to see them. And so I think that's going to significantly impact the number of providers that are even willing to see this patient population.
Yeah, you said a lot, so I'm going to comment in order. So one, you are absolutely right. All of these things, all this legislation doesn't change the psyche of a Medicaid patient. Forever and ever and ever, the primary point of enrollment or re-enrollment for patients is when they're sitting in the ED, because they don't think about re-enrolling and they don't think about their coverage until they're in the ED seeing their family practitioner, who's the ED doctor. Okay, so there's that. And then you talk about the cost, the $35 cost is like you mentioned, um, care. Like, how are they going to get there? They're going to bum a ride. They're going to take an Uber. Not sure. And then I'm kind of just curious. It's like, because it's been $3 for a long time. So like, how do you get to 35? Like, is this just like finger in the wind stuff? Is people just sitting around the table saying, well, hey, it's three now, but how's 35 sound? I don't know. I'd kind of like to see the behind the napkin beer math on how they came up with that. But it's just unattainable, and it's frightening in the sense that someone could present themselves in an ED today and be seen. Now to actually have to pay to be seen, that's going to be different. But I think hospitals they may have to revert to fast track, right? Having somebody there at triage to decide, okay, this is emergent, they need to be seen. This is non-emergent. This is a cough, a cut, a bump, a bruise, strep throat, somebody looking for Zithromax, something, right? Somebody looking for an excuse not to go to work tomorrow. But there's going to have to be somebody, hospitals are going to have to fortify the front lines in the ED to make sure that people are using their ED as the most appropriate way of care.
And I think that's a really good point. Hospitals for years have been really nervous about Intala, to the point that I think, they would prefer not to have the violation. So they just kind of leave the doors wide open. I've, constantly over the last 20 years had conversations with hospital executives and boards. EMTALA doesn't say, it says that you have to stabilize emergent patients and you have to give all patients the same access to care until they're stabilized. So to your point, that doesn't mean that you have to, see the bumps, the bruises, the cuts, the strep throat. You just have to get to the point where you're able to verify and offer them the same level of screening that you offer other patients to verify that it's not actually an emergency. And I think you're right that they're going to have to do that. But then the problem becomes you send them from the emergency room to your clinic across the street, and now they owe $35. So, which is, crazy. So it's like we're trying to get them to not use ER care, but coming to the ER is one of the exemptions where they won't owe $35. Going to a clinic, they're going to owe $35. So that completely changes the incentives of these patients that we've been trying to get out of the ER for years. And the other thing about, EMTALA is, in this act, in the BBB, I like how you're calling it the BBB. I'm gonna start using that because it's like a mouthful. And then last week I started adding the word bad in there, and mine was BBBB. And somebody was like, Elizabeth, the word bad is not in there, and I like psychologically just started throwing bad in there.
Well, it should be.
Yeah, right. It should be in there for as long as it relates to this, for sure. But so. A lot of the sound bites of this have been about getting the illegal immigrants off of Medicaid. I read some statistics that say at most we're looking at 1.5 million illegal undocumented immigrants on Medicaid, and we're talking about 77.9 million people on Medicaid. So to your point, we're taking these vast, brushes across the top to affect these very small groups. But as, most people on this call know, there's currently federal programs in place that do allow you to receive some funding back from the federal government for treating undocumented immigrants in the emergency room. Well, that funding is cut by the BBB. So you have one federal law, EMTALA, who's like, you have to treat these people. You cannot ask them about their citizenship. You cannot ask them about insurance. You have to treat them. And then now you have the federal government saying in another rule, well, we're not going to pay you anything for that. So, I mean, something has to give. So that's a horrible thing for the hospitals, because I tell people all the time, like, the thing with healthcare is like it's a benefit. You can cut it as much as you want. People are not going to stop showing up for the hospital. It's just not going to happen. So they're still coming. They're still undocumented, and then you're telling the hospitals, well, too bad, you have to treat them, but we don't care, and we're not going to pay you. And that's one of the parts that I've heard is going to likely be or has immediately been challenged. Is how can you tell us that we have to treat these patients, but on the other hand, there's no one to pay for them, and they can't, pay for themselves. So I think you're really right about the, tightening of the front and then really relying on your Medicaid vendors to help you try to capture as much information as you can with the patient when they're sitting there in front of you, to try to. I think about our normal screening exam for a Medicaid patient now, right? We ask, how many people are in your household, what's your household income. Some states there's a few additional questions. You're now going to have to ask these people, are you employed? Are you in school? How many hours a week do you work? Where do you work? Do you have a pay stub? I mean, the Medicaid screening just went from we had a quick screen that was like 4 or 5 questions, and now quick screen is going to be what, 15 questions. I mean, I actually, this literally just popped in my mind as we're having this conversation, but how do you see the whole process of screening these patients changing under all of these new requirements?
Well, yeah, they have to make additional changes to the screening because there's more information that's required. And then there's going out and getting proof of the evidence, getting proof of the volunteer hours. The volunteer hours might even be harder than the actual work hours because, I mean, anyone on this call can go out to the local food bank today and volunteer. They could go to the Red Cross and volunteer. They could go to a soup kitchen and volunteer. You could go anywhere. You can go to lots of places to volunteer, but it's not like they're handing out volunteers. I mean, slips at the end of the day to say, thank you, see you later. I mean, they have like a big chief tab and a fat number 2 pencil. They don't have any
Right.
technology
They don't keep records. Well,
Yeah.
yeah. And, well, that's a really valid point. How do you I mean, I could write you a note that says you volunteered at the food pantry for 80 weeks, 80 hours this week. They have no way, there's no way to verify whether that's valid or not. Because, and they're not going to all of a sudden start keeping rolls in order to help hospitals get patients Medicaid eligible. So yeah, I mean, I hadn't even actually thought about that. What happens if I write you a note that says, you volunteered for, I mean, I have to do this. I volunteer at my church, and I have high schoolers that, volunteer for me, and they bring me these forms and I sign them. But how are you going to verify that is, and when you're seeing them leaning, so we're not going to get our finalized regulations on these employment or community engagements until July. They're due in July of 2026 or into June 2026. So we're gonna get some more guidance on this, but you can already tell from the language that's in the BBB that they are really looking at extra verification. They're adding an extra address verification where you're going to have to verify an address on some federal system, which is a big deal because this is transient population. They don't always have a solid address. They're doing the death roll where you're going to have to bump your Medicaid roll up against the national death roll every quarter. So they're requiring all these extra validations. So I can't believe that when the work requirements come out, that they're not going to, the only things that are going to qualify are going to be, really specific verifications that just aren't possible, both for employment and for volunteering. When we were a lot of years ago, actually, when I remember, there was a push back pre-COVID, where a lot of the states were working on their Medicaid eligibility, and we're trying to get the work program thing passed. I think Arkansas and Georgia were the only two that were successful, but Kentucky and Virginia and some other states had tried, and then it got stuck in their courts. I know during that time, you and I were traveling around and talking to a lot of hospitals, and a lot of hospitals were gearing up for, okay, do we provide the volunteer opportunities? Do we go to our foundation and say, hey, you've got to create volunteer opportunities for these patients? Do you think that that's still a viable option that hospitals need to be looking at is if we can't verify their volunteer hours somewhere else, do we ask them to come volunteer at the hospital?
I think that's a great point. I think it's kind of that, that out of the box thinking that people are going to have to, they're going to have to stare up at their whiteboards, and they're going to have to Gantt chart it out to figure out, what avenues can we take as an organization to help these patients find places to volunteer. So in essence, it's just a completely separate category that hospitals and social workers and eligibility vendors didn't have to keep up with in the past. Now it's an additional data point that they now have to be keenly aware of, because we are going to have to tell patient 1, 2, 3 that your work requirements are now volunteer, or work requirements are now going to be expected. And here's a laundry list of places in which you can go volunteer. I think that's one of the things that's gonna need to happen. And I think part 3 for me, I think of the BBB, our talk, we need to get back to, because I want to get into the assess the financial impact for hospitals. But I want to make a quick point with regard to what is this going to do to the psyche of the state and county offices, and what is it going to do to all of our colleagues that work along the front lines at different points of registration, case managers, social workers. I mean, they're going to throw their hands up and say, what are we doing? Because these patients we used to be able to care for, because we know the people on Medicaid, they're repeat customers. They will utilize the hospital 3 to 4 times throughout the year if they have active coverage. So some of those people going without health care, I think there's going to be, I think that we're going to revert back to what I call compassion fatigue for frontline hospital staff. And I'm fearful of that kind of resurfacing.
Yeah, I mean, the strain on, everybody, the strain on the hospital staff, the strain on the people that work for Medicaid, the strain on the providers. One thing that we, haven't hit on that I mentioned at the beginning is, and, Donnie and I talked about this beforehand, you could literally talk about this for 3, 4, 5 hours. I mean, there's just so much. It's the largest change to insurance enrollment caused by a federal, law ever. It's even bigger than, and having a bigger impact than the ACA. And of course, the ACA had an impact in the other direction, which is also all being rolled back, which we haven't even, I haven't even touched on. But, as I mentioned at the beginning, you have both the fact that some people are going to become non-eligible for Medicaid and they're going to fall off the rolls. But you also have that with the states losing literally billions with a B of dollars of funding for their Medicaid programs. The only thing that is fiscally going to make sense is they're going to have to cut Medicaid benefits. And I went and read the Medicaid code, which was I actually hadn't done in a long time. But I went and I looked at, what is required to be, covered by Medicaid, and I was shocked at some of the things that are not required that we've just come to assume. So prescriptions are not required to be covered by Medicaid. Dental services are not required to be covered by Medicaid. Mental health care, not a required coverage under Medicaid. Specialty care, so anything outside of primary care, not required under Medicaid. Occupational, speech, physical therapy, none of that is required. Basically, Medicaid gives you inpatient hospital care and primary care, and that's it. That's all you're required under federal law to provide. So looking at some of these states that are going to have these huge, massive, almost 50% of their funding cut, billions of dollars, the only way they're going to be able to make it up is to change the face of the services they provide. And this is, a lot of the children's hospitals, the cancer communities, the special needs communities are really, really concerned about this, because all those patients are on Medicaid because of their disabilities. And then you're looking at a situation where they may no longer be getting paid or being covered for the things that they desperately need to get better and have better health outcomes.
It is quite the quandary, that's for sure.
And I was just shocked. I really was that so much of that stuff was not required to be covered by Medicaid. That is just it's just mind blowing. And I had some statistics about that. So last year, 41.5% of children on Medicaid or CHIP received preventative dental services. So that's half the kids on there are using the preventative dental services. And then the mental health care thing alone, last year there were 13% of children and 19% of adults enrolled in Medicaid received mental health treatment. And then 12% of children and 25% of adults enrolled in Medicaid took a prescription for mental health treatment. So you already have these at-risk populations,
The what?
and now you're taking away the services that they've received that are barely helping them, hang on. And you talk about the back to the fatigue on the Medicaid offices in the front line.
Okay, yeah, that
These
sounds
people are
good.
now arriving at the hospital in a mental health crisis.
Yeah, I mean, I've
Hey
read.
guys, sorry to
you-
interrupt. Can everyone just double check and make sure that you are on mute? We're getting a few interruptions. Thanks.
Thanks, Angela. Yeah, I mean, like you, I've read the passages just ad nauseum, and as you talk, my face continues to get redder and redder because some of this stuff is just like it is really just mind-boggling. Because take away those type of benefits or those type of benefits to those who are suffer from mental health and need the counseling and need medication, especially those with mental health. I mean, mental health is real. The struggle is real, regardless of age, but especially taking the mental health coverage away from children. I mean, that is just catastrophic.
Well, and dental care. I mean, taking preventative dental care away, from children is catastrophic. And then, I've read some stuff that's talking about like you're going to get in a situation where people are going to have to move around the country to get services for their children. So if you live in a state that cuts all of the PT, OT, speech therapy, and you have a disabled child, your only option is going to be, maybe to move to a different state that maybe has that coverage. So you're going to have that kind of stuff happening too, is it's going to be such discrepancies between the different states and how they choose to figure out how to fund this. So now we're talking about people showing up in the emergency room that have had no preventative care, that maybe we already have plenty of people showing up in the emergency room with a mental health crisis, but more people showing up with a mental health crisis, people that are not compliant on their prescriptions because they can't get them refilled, people that are hungry. You and I talked about this before we got on the phone. Like, it's just very hard to understand how in one of the most developed and richest countries in the world, that this is literally the face that what we're staring at as a very, very real possibility, based on what we know about this population of people. So Donny, if you were going to give a hospital executive team, a revenue cycle team, kind of the next steps of what you think that they should do to begin to think about how to address this.
Great question, thanks. And I've had this question. A few people reached out to me and said, "Will you all please cover this particular topic?" So, assess the financial impact by analyzing their own Medicaid population. So all you business analytics people out there, here's an opportunity. It's in essence, all the hospitals have to leverage their comprehensive data sources. They have to go back. They have to utilize their Medicaid claims, their encounters, their enrollment data to build a detailed profile of what their Medicaid population is. And then they need to stratify and segment the population, use risk stratification tools, analytics to identify high-risk groups within your Medicaid population, such as those that have serious mental illness or frequent hospitalizations or complex social needs. And then segment the patients by age, geographic location, chronic conditions, or social factors. And then, analyze the utilization and the outcomes. So track key metrics such as primary care utilization, emergency department visits, and hospital readmissions. For example, compare the percentage of Medicaid beneficiaries with at least one primary care visit to those without, and analyze the trends over time. And I think and examine the difference in utilization outcomes between the subgroups, like those with an SMI, a serious mental illness, and those without, or those experiencing homelessness, those who are stably housed. So I think the most important part, I think the plan or the blueprint needs to start with hospitals identifying what their risk is. And then once you know what your risk is, then you can take a deep dive like that, like I went that in. You take a deep dive into the practical steps that they need to take to ensure that their uninsured population, underinsured population have the best possible chance in obtaining government assistance or retaining government assistance.
And I think you're right. We're no longer running data on Medicaid or not Medicaid. Right now we look at eligible or not eligible, basically. They need to look at eligible, not eligible, working, not working. To your point, they need to break it down by the chronic health conditions, the things that may end up cut, the mental health. I mean, that's really, really good advice, is to run different models looking at, all sides of this patient population. And I think sharing that with your state representatives, I just think knowledge is power. And the real only way this is going to be fixed is, some at the state level with the way that the budgets are reallocated, but at the federal level of really making people understand, what is going to happen, and using actual data to back that up, I think leaves hospitals in a really great position. The only thing that I would add is that we always, as the hospital, end up having to be the educator. All of these things, 501R, surprise billing, all of this stuff, the hospital ends up being the one having to educate people. So what kind of, active, we've had some providers in the past ask us to come and do Medicaid enrollment, days at their facility or in their community. I think hospitals and providers are going to have to be more active in doing things like that, actively going out and trying to find these people before they fall off the roll or before they come in the hospital with a serious medical condition, and just educating them and helping them, providing them the services for the Wi-Fi, helping them, read the application. That's all going to become extremely important as we go forward. And Donny and I I'm going to have you throw out the question that you threw out to me before we got on the call with everybody about who's going to take the blame for this.
Yeah, that's a question that I have in my head, is that when I'll just say patients, I mean, when the patients present themselves, it's like, who are they going to blame? They're going to blame the hospital? Are they going to blame the government? Are they going to blame the politicians? All I know is the politicians aren't at the hospital. The government's not at the hospital. So guess what? They're going to blame all of us who work at hospitals. And getting back to your point about the data, all the data that I just talked about to assess, I think I would suggest that hospitals get that data, and they're going to have to start breaking bread with their county offices and say, hey, here's the Medicaid utilization and population that we dealt with in years past. What can we do? What can we do together to help to ensure that these people continue to get coverage? So there's going to have to be increased lines of communication are going to need to be open, because we're working in a brand new world. Because as we're on camera today talking about it, these same conversations are going on at the state level, I hope, with someone trying to figure out how they're going to capture all these new verification and what's going to be accepted as valid and not valid, especially as it pertains to work credit and volunteer hours.
Well, and I think you make a good point about they don't have the technology at these county offices to handle some of this stuff. So where does the hospital step in via their vendors and provide the technology necessary to meet some of these requirements? I think that's another thing that is going to have to be looked at, is like, how can the hospital utilize technology they may already have to assist these state agencies in a way they never have before.
Yeah, and I think hospitals they're going to have to take their Medicaid data, their claims, their remits. They're going to have to take that data. Then they need to do an eligibility check for each and every one of their Medicaid patients to find out when their coverage elapses, and then go out and start some type of initiative to contact these people to get in front of the curve and say, hey, Mrs. Smith, your coverage expires in 2 months. We'd like to help you reapply. And then you do that by way of, phone campaigns, text campaigns, or you send somebody out there to get them re-enrolled, or, you outsource that to an agency that does what is now called recertification programs to ensure that to help people that we know that are once categorically eligible that have coverage to ensure that they get that they extend or re-enroll for their Medicaid coverage. So that way they don't present in their EDs as a self-pay patient, they present as a Medicaid patient, and hospitals aren't waiting on their money.
Well, and that's like you said, it's not, none of this is going to change the psyche of a Medicaid patient. None of this is going to change the social determinants of health. None of this is going to change the current chronic health conditions this population suffers. None of this we're going in the opposite direction as far as assisting with food insecurity and things like that. And the average Medicaid patient, traditionally, they don't care if the hospital gets paid because they're not going to have to pay the hospital. So the motivation for them to provide all this documentation, part of what we've used over the years to push that notification has been, hey, you're going to get all of these other benefits if you apply for Medicaid. Well, now all those are cut too. So that's another thing is like, how do we incentivize these people to participate? I mean, I don't want to provide all that documentation. I don't want to do all that work. I don't care if the hospital gets paid. And I think that's going to be a really big issue too, is like, what is the incentive for this patient population? And it's not the whole Medicaid population, right? But there's a large part of this population that, what is going to be the incentive for them to even try to participate in all of this? They don't care if you get paid.
Yeah, and then it's in the past they had a Medicaid card and they had one of 20 services available to them. Not that they used each and every 20, but if they wanted to, it was afforded to them. But now it's like they might have 3.
Right.
Goodbye counseling.
Yeah.
Goodbye mental health.
Goodbye prescription coverage. Like, I mean,
Yeah. Oh, yeah. Well, goodbye physicals. Goodbye annual checks for children.
Right. And so, but what, like the prescription coverage thing, immediately what's going to happen is they're going to release formularies that have nothing on them but amoxicillin and like the most basic, generic drugs. They're going to immediately cut all the expensive drugs, which are going to be your infusions, your chemo, all these things for these chronic health conditions. That's going to be the first to go because that's the most expensive. It's just, yeah. The more I'm like you, the more I talk about this, the more days I talk about it, like I get increasingly frustrated, I think is a good word. Just because the implications of this are so obvious for anyone who has worked in this, and the inability for other people to see it and understand the significant road that we're headed down is really, really frustrating. I know I have spoken to a few hospital boards. I know Donny is also willing and able to speak to, boards, organizations, state governments, things like that, to just really help people understand more of a hands-on approach to this. We've already blown through an hour, which is crazy. This is our second hour talking about this. We may have to do a version 3 just because there's just so much. I really, really appreciate your time, Donny. Your knowledge and your hands-on access and treatment to this population for your entire career is so valuable. I can read the law all day long, but having somebody that can bounce ideas off of that really understands it at a granular level is really awesome. So I appreciate you participating today. And is there anything final that you wanted to say that we didn't get to, or just closing thoughts?
No, I just appreciate the opportunity to use this as a platform to talk about Medicaid enrollment is already hard enough because we're already talking about Medicaid enrollment we're like acting like it's easy peasy now, but like that's still the same thing. That's still difficult. It's just not like sign here, swipe left, you have it. There's a lot that goes into that. So now it's just like you're just adding additional layers and hurdles, and I think that it is just going to be it's going to be a maze of frustration, and I'm very concerned about patient outcomes, and I'm concerned with the psyche of the hospital front staff and social workers and caseworkers, and because it goes in people that work in the Medicaid enrollment space or the social work space. It's like those people, they live and breathe to help people. So to ask a Medicaid patient to pay for services goes against every strain in their body, goes against everything. If they wanted to be a collector, they'd be a collector. They're not a collector. They're not playing cash check or charge with people. They're like, how can I help you? And now it's like what's available to them as resources is being stripped away. And that part of it, I'd like to continue to look at, and I'm going to continue to take a deeper dive into that. And
No, yeah,
see how,
I actually
see that
think, you know,
affects.
the deeper dive into the, you know, I think we could do a whole social determinants, you know, mental health, just looking at that and that for an hour. I really appreciate your time today. I really appreciate everybody for joining in. There were some questions in the chat about the timeline. That's something that's also very different about this bill. Usually when we have a bill like this, there is, you know, there's an active, there's a, you know, it's signed on this date and it goes into effect on this date. This bill has like 10 different effective dates in it over a period of, or actually over an entire decade. So that's really also frustrating and trying to figure this out as these things don't all become active on the same day. I know that Donnie and I have a timeline. We can get that posted onto the Altum website, or any additional information. You guys can reach out to us on LinkedIn. But I really appreciate it, Donnie. Thanks for spending time with us today. And, you know, stay tuned for our next deep dive, which is probably going to be about the BBB.
Thank you, Elizabeth. We all appreciate you so much. You keep fighting the fight.
Thank you.
Have a great day, everybody. Take care.
Bye.
Bye-bye.